Hello and welcome to our Chapter 16 video lecture where we're going to talk about pain, temperature, sleep, and sensory function. So first we need to discuss what pain is. It's an unpleasant sensory and emotional experience that is a protective phenomenon that is associated with either an actual or potential tissue damage that is described in terms of something that is uniquely experienced by each individual. And it's also very subjective from the patient, like we mentioned, so it can't really be defined, identified, or measured by an observer. And here is another definition of what pain is from McCaffrey. Pain is whatever the experiencing person says it is, existing whenever he says it does. And so we need to give attention to what a patient is telling us. This can also become complex if the patient has perceptual dominance, meaning that if they have pain at one site, it may mask other painful areas that they have. People that have severe pain in one knee, for instance, is more likely to experience less intense chronic back pain. And I just want to mention 4 different theories of pain. You might dive into this detail a little bit more in a nursing course. There is the specificity theory, in which pain is directly related to tissue damage. While it could be useful for a lot of injuries, it doesn't really explain the psychological or chronic pain factors, though. The other theory is called the pattern theory, and this means that the pain is based on intensity and patterns of nerve signals that come into our central nervous system. But this theory doesn't really account for all pain experiences. Third, we have the gate control theory, in which we have a gate in the spinal cord that controls the pain signals. So then our pain signals open the gate, while our non-painful stimuli, such as touch, can close or partially close it, which can help reduce the pain. And lastly, we have the neuromatrix theory, and this kind of expands on the gate control theory we just talked about, because it starts to consider the genetic, psychological, and cognitive factors, and our brain can start to generate pain patterns even without external stimuli, which really shows adaptability. So with those in mind, let's jump into the neuroanatomy of pain. First, let's talk about this term nociception. It refers to the processing of harmful stimuli through normal functioning of our nervous system. And I just want to do a quick review of our afferent and efferent pathways, because these are going to be the processes in which we use to communicate pain throughout the body. So if you remember, we have a receptor. So here we're having some type of pain stimulus, and soon we're going to talk about that receptor being called a nociceptor, basically a pain receptor. And we're going to use some afferent fibers or pathways to bring in that information through our within our peripheral nervous system. It travels into our spinal cord, and notice how this is through the dorsal root that we are going through and making it into our spinal cord, and eventually it is going to ascend to areas of our diencephalon, like our thalamus, our epithalamus, and hypothalamus, and eventually our cortex. From there, we're going to have our interpretive center, which is really the subcortical and cortical networks. Remember, we talked about the cortex of our brain. It can also include our brainstem, our midbrain, parts of our diencephalon again, like the thalamus, epithalamus, hypothalamus, and the cerebral cortex itself, as we mentioned. And from there, we are going to move through efferent pathways back down through our central nervous system. So we're going through our midbrain, the medulla, and eventually down into our spinal cord once again. and back to our dorsal horn of the spinal cord, and information will flow out depending on what we have going on, right? If it's a painful stimuli that we need to use our muscles to pull away from, we're going to go in this direction, for instance, or we might connect over to the other side of the body for whatever reason. And so next, let's talk about the full pathway of pain. And we're going to use this using 3 ordered neurons. So we have a primary ordered neuron, which we are going to refer to as our nociceptors. Then we'll talk about our secondary order neurons, which would include our spinal cord, or neurons traveling from our spinal cord to the thalamus. So this is kind of a path right here with the second order neuron. And then we would have our third order neurons that's going to go from the thalamus over to our higher cortical areas. It could be an area in our limbic system, our frontal cortex, or sensory cortex that we would find within our parietal lobe. Landing back on our nociceptors, these are going to be free nerve endings in our skin, muscles, joints, arteries, and viscera organs that are responding to different type of stimuli that could be painful. Now, these painful stimuli could be mechanical, meaning we have some kind of pressure or mechanical distortion. It could be thermal, meaning we have extreme temperatures. Chemical, meaning we've got some type of acid or chemicals of inflammation, such as bradykinin, histamine, leukotrienes, or our prostaglandins. And so from those areas that we discussed, we are going to have an afferent neuron move through, and the cell bodies, I wish they put a little, let me see if I can add this in. I wish they put a little cell body in here, because this is our dorsal root ganglion where the cell bodies of these afferent neurons are going to be found. We could also find some of the cell bodies within the trigeminal ganglion of our face if we're experiencing pain moving in from that area. So we also know that this is going to be unevenly distributed throughout our body. If you remember the homunculus of our sensory cortex, we know that we're going to have more nociceptors in areas like our fingers, or sensitive areas like our lips, and so forth. And so we can detect a wide range of stimuli, if you didn't gather that yet. And these are communicated through different afferent neurons. So you can see them listed here and over in the text on the left. So a delta and a C fiber are the 2 different types that we have that are primary order neurons. You could see that the A delta is myelinated and the C is unmyelinated. So our A delta are going to be larger. They're going to be able to rapidly transmit any sharp or well-localized fast pain, such as intense heat or a pinprick that could cause a spinal reflex withdrawal. And like I said, we can sometimes, sorry, my mouse is moving slow for some reason, sometimes communicate that to the other side if we need to, let's say, stand on one limb while we pull another one away. Our C fibers are going to be the most numerous and are small and located within our muscles, tendons, organs, and in our skin. So they slowly transmit dull, aching, or burning sensations that are poorly localized. I actually have this going on in my shin right now. I did an MRI and I had some edema in there, and I get this dull, aching pain. So I know those are my C fibers that are communicating that information. Now we're going to see them, these primary neurons, communicate with our secondary order neurons, and these could either be excitatory or inhibitory interneurons in an area known as the substantia gelatinosa of our dorsal horn. You could see that these are different colors within these areas representing different regions. And so we can think of these as being projection cells. They are crossing over. So we started here and we are crossing over to the spinal cord to project over to the other side. And then they'll become our third order neurons, or rather not become, but synapse with our third order neurons, which are still going to be afferent or sensory neurons, but they're going to travel through an area known as, and it's probably cut off a little bit here on the side, but it's known as our spinothalamic tracts. And these spinothalamic tracts carry information to our reticular formation, our hypothalamus, thalamus, and limbic system, so that we can interpret pain location and intensity. Now, there are actually two spinothalamic tracts. There's an anterior one, they have it listed over here, that is going to carry fast impulses of acute, sharp pain, whereas our lateral spinal thalamic tract is going to carry slow impulses for dull chronic pain. So notice how these red and green arrow colors are kind of matching with the fiber types that we talked about. And I like this illustration here on the right hand side because we can really see this would be our first order neuron, our second order neuron, and then our third order neuron here. And we're going to talk through this describing 4 phases of nociception. So that first phase is going to be transduction, where we have the activation of our nociceptors. So it's really starting when we have damage to the tissues because we're exposed to some type of chemical, a mechanical change, or thermal painful stimuli, the ones we described before. And it's converted into an electrophysiologic type of activity within our nerves. Then we are going to move into transmission. And you could see that over here where we're in the spinal cord, where we're moving from that dorsal horn area of the input in that spinal cord area, and it's going to move up the spinal cord. So we're conducting those pain impulses along those A, delta, or C fibers into the dorsal horn of the spinal cord, and eventually we're heading up to the area of reticular formation, our hypothalamus, the thalamus, and our limbic system. And what we want to happen is perception, our conscious awareness of the pain. And we can use a couple different systems in order to do this. We create a pain matrix that's made up of these networks of our cerebral connectivity. So the first one we'll describe is sensory discriminative system. And this is mediated by our somatosensory cortex. So if you remember where that is in our our parietal lobe, and it's responsible for identifying the presence, the character, and location of the intense pain so that we're able to kind of describe that pain, right? And then we have our affective motivational system, and this determines a person's conditioned avoidance behaviors and their emotional responses to pain. So it'll be mediated through our reticular formation, where we're getting those sensory inputs, our limbic system, so there's that emotional part, and our brainstem. And lastly, we have our cognitive evaluative system, and this is going to overlie a person's learned behavior concerning the experience of pain, so that a person can modulate the perception of pain, and it's mediated through the cerebral cortex, where we have the gray along in here. And this matrix, of course, could be influenced by genetics, sex, cultural perceptions, expectations, role socialization, our physical and mental health, and our age. We know that infants are very sensitive to pain, while the elderly, we have pain thresholds that may be elevated, meaning that they're not going to be as sensitive to pain. So let's talk about what we mean by those terms, pain threshold and pain tolerance, because they are a subjective phenomena. So our pain threshold is going to be defined by the lowest intensity of pain that a person can recognize. Intense pain at one location can sometimes increase the threshold in another location. We kind of talked about this earlier, so that an individual that has many painful sites may report only the one that is the most painful. After the dominant pain is diminished, that person may identify the other painful areas. So you might see this happen through doing something like PT or getting localized treatments where one pain will subside and then they'll start to feel the other ones. Now with pain tolerance, this is going to be the greatest intensity of pain that a person can handle. And this is going to be very individualized. And we do see decreases when we have repeated exposure to pain, fatigue, anger, boredom, and so on. And the last phase is going to be modulation. And you could see this over at the number 4 here with information coming back down. And this is when we get a increase or decrease in transmission before, during, or after that pain is perceived. Let's do a quick little check on knowledge. So you have this question here. A nurse is recalling the reflex withdrawal, so we see that as an example here, of an affected body part, the finger in this case, from painful stimuli before the pain is perceived. And this is going to be controlled by, we have our myelinated A beta fibers, unmyelinated C fibers, unmyelinated C alpha fibers, and myelinated A fibers, not A alpha. So which one of these do we think it is? And my little hint is going to be that this is going to be a fast impulse. It's going to be an intense pain, right? So that should give you a clue that it is going to be our A fibers. Specifically, it would be our A delta fibers that would cause a fast transmission and the reflex withdrawal of that affected body part. With our A beta, these are really large myelinated fibers and they're going to transmit touch and vibration sensations, so they're not really going to be involved in pain. And then with our myelinated C fibers, that is going to be stimulated by our mechanical, thermal, or chemical pain receptors, and it's going to be that slow, dull, aching pain. And then we do not have any A alpha fibers. Now for our neurotransmitters of our pain modulation, we're going to be able to control this in different areas like the peripheral nervous system, spinal cord, and brain. And we'll see that it's triggered by tissue injury and or inflammation. So when we have excitatory neurotransmitters, we will have secretion of prostaglandins, histamine, and bradykinin when we have that tissue injury. And if there's a type of chronic inflammatory lesion, we tend to see more of our lymphokinins. Now the neurotransmitters listed here are glutamate, aspartate, substance P, and calcitonin are going to be the ones that are found within our brain and spinal cord. Whereas our inhibitory neurotransmitters that are found in our central nervous system will be GABA and glycine. GABA, by the way, stands for gamma aminobutyric acid. And then we'll find serotonin and norepinephrine as well as inhibitory here, but they are going to be excitatory within our peripheral nerves. One of the ways that we can also modulate pain is by using our endogenous opioids, meaning they are produced within our body. And we call these morphine-like neuropeptides. And so when these are produced within our body, so for instance, this neuron over here is going to have our endogenous opioids attached to these opioid receptors, and this is going to inhibit pain impulses in our peripheral nerves, our spinal cord, and our brain. So it's really preventing the release of neurotransmitters here that would communicate to the thalamus that we are experiencing pain. When we have inflamed tissue within our peripheral nerves, we can also have opioids that are produced and released from immune cells. So this is important, and we have these opioid receptors throughout our body so that we can have a sense of well-being, and also we can modulate a lot of our physiological processes, such as having control of our respiratory and cardiovascular functions, our stress and immune responses, our gastrointestinal function, and having reproduction or neuroendocrine control. So as we gathered from the previous slide, our endogenous opioids are inhibiting pain impulses in our spinal cord, brain, and peripheral nerves. And so we are going to have this group of our enkephalins that are the most prevalent natural opioids. First up are endorphins that many of us have already heard about. We call this our endogenous morphine, and they're produced in the brain and are probably the best studied endorphin in the body. And they're going to bind to something called mu receptors, and they help give us our greatest sense of exhilaration. It's a natural pain relief. And our dynorphins are going to be the most potent endogenous opioids. They are strongly binding to our kappa receptors, and they impede pain signals, and they ironically will play a role in our neuropathic pain, which I'm going to tell you what that is in a few slides, and in mood disorders and drug addiction. And then we have our endomorphins, which are also going to be opioid peptides, and they're a part of our body's natural pain relief as well, and are found in our central and peripheral nervous system. They are going to be highly selective for our mu receptors as well. And all of these will have pharmacologic actions, that are similar to morphine. Hence we call them endogenous morphine. It's what we create within our own bodies. And they're going to bind as direct agonists to all of our opioid receptors. Another naturally occurring neurotransmitter in our body are the endocannabinoids, and these are synthesized from phospholipids, and we classify them as eicosanoids. So they are going to act as signaling molecules, and they help bind over to our cannabinoid receptors, and these are going to be located throughout our body. And so cannabis can produce a resin containing these cannabinoids, and this has proved to be analgesic in humans. There are some drawbacks though. They are psychoactive and have addictive properties. And some of you may have heard of people taking CBD. The way that works is it's going to suppress the breakdown of anandamide, which is a naturally occurring cannabinoid in our body that is responsible for activating the cannabinoid receptors. And so we have that neurotransmitter kind of sticking around a little bit longer and giving these reduction in pain effects. Next, let's discuss some of the pathways of modulation, and we're going to discuss our descending inhibitory or facilitatory pathways. And so let's walk through the pathway really quick first, where we are going to have it start over in this periaqueductal gray. Now, this is going to be an area of gray matter within the midbrain. We're receiving the pain information, and we want to relay that down to our rostral ventromedial medulla. We're just going to call this our RVM for short. And the neurons within this area are then going to send signals down to our spinal cord, where we are going to activate our endogenous opioid system so that we can suppress pain. Now, we can do this in a couple different ways. We can obviously activate the opioid receptors. We can inhibit the release of excitatory neurotransmitters, release inhibitory neurotransmitters, or stimulate the inhibitory interneurons. Conversely, when we are stimulating something, specifically our efferent pathways, that's going to inhibit our pain signals. And then we've got our segmental inhibition of pain, where our A beta fibers are stimulated and our impulses will arrive at the same spinal level as the A delta or the C fiber impulses, and will stimulate that inhibitory interneuron, and that will decrease our pain transmission. We also have our category of conditioned pain modulation, in which we're going to see this diffuse noxious inhibitory control known as DNIC. When our pain is relieved when we have two noxious stimuli that occur at the same time at different sites. And we see that this is a deficit in a large proportion of chronic pain patients. We describe this as pain inhibiting pain, and it usually occurs when we have a response from a painful stimulus that's inhibited by another one. So we've got typically spatially distant painful stimuli going on. And then another pathway is our expectancy related cortical activation, where the cognitive expectations can have an effect on pain. So this is where we see a lot of the placebo effect taking place. An example of this would be, I heard a story way back when about there was somebody working in a construction site and they saw a needle go all the way through the sole of their boot and through the actual shoe, and it was sticking out and they could see it piercing their boot. And so they are crying in agony and so much pain. But then when they went to the ER and they cut the boot away to see what the injury was, the nail had actually moved in between their big toe and their second toe, and there was no penetration through the foot. And so that was more of like a expectation of that pain rather than actual pain taking place. This can also happen when a person anticipates a painful stimulus, and that leads to increased activity in brain regions known as the anterior cingulate cortex, even before the actual pain is experienced, and that could potentially cause them to perceive the pain as more intense due to their heightened expectation of that discomfort. I put this slide in here just to give you a general, almost like a bird's eye view of the different types of pain that we are going to talk about. So we have our nociceptive pain. This is pain within our normal tissue injury from a known cause, and we can classify it as somatic and visceral. We've got non-nociceptive pain. That's going to include our neuropathic pain. That could be peripheral and central. And then we are also going to classify the pain based on the duration. So we'll talk about acute versus chronic, and that is going to be less than 3 months versus more than 3 months. So let's get into our acute pain first. We see that acute pain is more of a protective type of mechanism. The pain is there to alert us that there's some type of condition or experience that is happening that is harmful to us. And it can mobilize the individual so that we could take action in order to remove whatever that harmful thing is. And so we could describe it as being transient as well. Acute meaning like a short duration. So saying it's transient means that it's temporary or short-lived. So our acute pain will last for a short amount of time and resolve once that underlying cause, whatever it is, an injury, recovering from a surgery, or inflammation, will be either treated or healed. And it can begin suddenly and is relieved after the pain stimulus is removed. And we can classify it as either being somatic or visceral. So when we have acute somatic pain, it can arise from our skin, our joints and muscles, and we can even throw bone in there. And if it is going to activate through our A delta fibers, we will have a sharp and well localized pain. And if it is our C fibers, then we will have a dull pain that is achy, throbbing, and poorly localized. Now, when we have an acute visceral pain, that means the pain is coming from our internal organs or the lining of our body cavities. For instance, it could be like our pleura covering our lungs. And the pain is going to be poorly localized, as a result of fewer number of nociceptors in those areas, and we might have an aching, gnawing, throbbing, and cramping quality to it, and it often will radiate as a referred pain. And you may have heard of referred pain before. This is going to be a pain that's felt in an area that is removed or distant from where that, I guess, origin of where the damaged tissue is, where that actual pain should be. And so the area of referred pain is supplied by the same spinal segment as the actual site. And that's why we see this traveling of it. And it could either be acute or chronic. There's a couple examples that you may see highlighted around here. For instance, if someone is having a heart attack or a myocardial infarction, we do see it spreading to areas like the left arm that you could see pictured over here. You could also see it over here, so we could have some back pain. Sometimes we even see jaw or I think chest pain is pretty obvious, but we can also have shoulder pain, especially in women. If somebody has pancreatitis, they might have back pain. Someone has renal disease or kidney stones, we might see pain within the lower abdominal or flank pain. In men, they can even have pain in the buttocks area. And if somebody has pain coming from the gallbladder, it can even travel up to the upper right shoulder or the right upper quadrant, which kind of makes sense because that's around where the gallbladder is. With our uterus, we may have back pain. For some of you that have menstruation, you might already feel this back pain, even when the damaged tissue, I shouldn't say damaged, but the tissue that is shifting and changing within the uterus is obviously in the pelvis. And if we have cysts on our ovaries, we may have pain in the lower abdominal region or just a generalized abdominal pain that's taking place. Now let's talk about chronic pain. And just as a quick reminder, we are talking about nociceptor pain right now. So with chronic pain, we see that it's lasting longer than the expected healing time. Usually it's going to last at least more than 3 months. It says to 6 months, but of course we know with chronic pain it can last longer, and typically this isn't going to respond to therapy, and it's serving no protective purpose, and it may be ongoing or intermittent. So this is thought to be caused by dysregulation of nociception and that pain modulation process. It's also thought that it could be manifestations due to stress, and we can see that it can cause behavioral or psychological changes such as depression and anxiety. So typically people with chronic pain, if you see a HESI or an NCLEX question about this and they're discussing pain, you also want to be cognizant that they may be having some type of depression or anxiety going on. And persistent pain causes physiologic adaptation. And I wanted to list just a few of these types of chronic pain, just something to be aware of. I'm not going to go through each of these because I think they're pretty self-explanatory and you could find a bit more information in your book. Now let's talk about our non-nociceptive pain, which is going to be our neuropathic pain. And this type of pain basically originates from abnormal nerve signaling, and it could be difficult to manage. It can be caused by a couple different things, such as peripheral nerve damage. We tend to see this in patients that have diabetic neuropathy or post-herpetic neuralgia or carpal tunnel syndrome. We can also have some central nervous system disorders, such as if we have damage to the spinal cord, or people that have multiple sclerosis where their myelin sheaths are damaged, or patients who have had a stroke. It could also be due to infections such as shingles or HIV-related neuropathy. And we know that shingles travels along the nerves, right? And then we can also see it in toxin exposure or medication side effects. So for instance, people that have chemotherapy-induced neuropathy. And the type of symptoms they tend to have are more of a burning, shooting, or shock-like or tingling pain. We can also have other symptoms, of course, something like numbness or an electric shock type of sensation, or maybe the pain worsens at night. And we can have patients communicate this pain by using pain scales. There is a neuropathic pain scale and what's called a DN4 questionnaire. We can also ask the patient to maybe assess some of the triggers to this pain, like when they're in the cold or stressed or when they are moving around. And also you want to ask your patient if they're having any sleep disturbances or, again, that depression and anxiety. Now, we can classify this as either peripheral or central. When it's peripheral, it means that these injured nerves become hyper excitable. And with the central, it's caused by some type of lesion or a neuroplastic change in their brain or spinal cord. So in the example on the right-hand side here, we see peripheral neuropathy, and this is going to be when we don't see that proper functioning of pulling your hand away from the candle. So it could be due to muscle weakness where we're unable to pull the finger fast enough away from the flame, and here we have numbness, so we don't even feel the pain of the heat. In this instance, an example of more of a central type of neuropathic pain would be something like phantom limb pain, where it's going to be a pain that results from abnormal nerve signaling rather than having direct tissue damage. And it can happen after limb amputation when the brain and the spinal cord are continuing to receive pain signals from nerves that once served that missing limb. So let's go ahead and do this question here. Ignore the question one here, but a 15-year-old male hits his finger while hammering a nail. Which of the following best describes the type of pain he would feel? Is it visceral, somatic, chronic, or neuropathic? If you said somatic, you are correct, because it's superficial, it's coming from the skin or close to the surface of our body, whereas we know that neuropathic and chronic pain are going to be characterized with increased sensitivity to painful stimuli, and visceral pain is from our internal organs, which is not affected when it's a finger. Now let's go ahead and shift gears into temperature regulation. And we know a way to discuss that is through the term thermoregulation, and it's achieved through a precise balancing of heat production, heat conservation, and heat loss. And the normal range is going to be about 36.2 to 37.7 degrees Celsius, or in Fahrenheit, it would be 97.2 degrees to 99.9 degrees. And we tend to see that women are going to have a wider fluctuation in their temperature than men. It is also going to vary in response to location, activity, environment, and our circadian rhythm. Now, our temperature regulation is mediated by our hypothalamus with some help of our endocrine system. And we have our peripheral thermoreceptors. You can see some of those thermoreceptors in this illustration here, where it's located within our skin. We also have those thermoreceptors in our liver and our skeletal muscle. And our central thermoreceptors are in the hypothalamus, which we don't see pictured here, but would be in the lower region of the brain here, our spinal cord, and our viscera, meaning our organs. So let's talk about heat production first. You may remember this homeostasis illustration of our thermoregulation. And so if we are going to produce heat, we can have some chemical reactions of our metabolism work in our favor. So those are going to be those biochemical processes that take place in our cells to maintain life. These reactions, if you remember, will include catabolism and anabolism, where we're, for catabolism, breaking nutrients down to produce energy. And for anabolism, we're going to start building those smaller atoms or molecules into complex molecules for growth and repair. And we know our skeletal muscle tone, and through contracting those muscles, we're able to produce heat. And through something known as chemical thermogenesis, which is also referred to as non-shivering thermogenesis, is going to be a process where our body is going to generate heat through metabolic activities rather than our muscle contraction. And so this mechanism is typically going to occur in our brown adipose tissue, and it's regulated by our sympathetic nervous system and through hormones like norepinephrine. So these I feel like sound pretty similar. Think of this as it being all of our biochemical reactions and having heat more as a byproduct. It's happening all the time. Whereas with this, it's a very specific process that is used when we need heat production. And primarily it works in response to cold exposure. And again, it's going to rely on our brown fat to cause this process to take place. Then we have our heat conservation, where we can cause vasoconstriction, basically pulling the blood away from the surface of our body so that we can retain it more, so that heat doesn't radiate off of our skin. We can shiver and contract those muscles more to produce heat. And then we have voluntary mechanisms such as wearing warm clothes or being indoors with heat. Then we've got our heat loss. So we have a couple different terms here, and it might be a little difficult at first to differentiate these, so let's talk about them. With radiation, our skin temperature is greater than the air temperature that is surrounding us. So we want that transfer of heat, let's say we're really hot, to leave our body and move out into the environment. Then we have conduction. This is going to be when we have the transfer of heat from the body to a cooler surface by direct contact. So for instance, I go to a lot of ice rinks to watch my kids play. So when I sit on that cold bleacher, then we are transferring the heat from my body to that cooler surface through that direct contact. Then we have convection, in which we are moving that heat from the body to a moving liquid or air. So you can think of this as you going into a pool of maybe some colder water, and that heat leaving your body and entering the pool water. Then we have vasodilation. This is diverting warm core blood to the skin surface. And then we have our evaporation, where we are going to be really hot, so our body is going to sweat, and that is going to vaporize at our skin surface, and that will cool us down. Our decreased muscle tone is when we have that exhausted feeling that is caused by moderately reduced muscle tone and curtailed through our voluntary muscle activity. Increased respiration is when the air is exchanged with our environment through our normal process, so it doesn't have a big effect on our heat loss. We've got voluntary measures, so stretching out, slowing down in response to having high body temperatures, increasing our surface area that is available for heat loss, so wearing light colored clothing or not as large of clothing, and also wearing something that is loose fitting helps. And then adaptation to warmer climates, where it's a gradual process that is going to begin with having some weakness and feeling faintness, and then going into increased sweating. We start to see a lowering of the amount of sodium we have in our body, a decreased heart rate, increased stroke volume, and in the end, we have improved warm weather functioning and decreased symptoms of that heat intolerance Now let's do some pediatric considerations. Infants are going to produce sufficient body heat, but they're unable to conserve heat produced. And we need to remember that they have more of that brown adipose tissue, and this is what helps them produce that body heat that we talked about, right, with our heat production. We also need to note that they have their small body size and a high body surface to weight ratio. They have thinner subcutaneous skin, fascia, which means that that layer is not going to have as much adipose tissue. They also don't have the ability to shiver and have lower sweating rates and a higher peripheral blood flow in the heat. So we have to keep these infants warm. Now for some geriatric considerations. They are going to respond poorly to temperature extremes. Blood circulation and vasoconstriction or vasodilator responses are going to be slowed. They will have some skin changes and decreased heat producing activities and may possibly have diseases that affect their thermoregulation. We'll also see that their metabolic rates are decreased. They have decreased shivering, or if they do shiver, it's ineffective, and their sweating and perceptions of heat and cold are decreased. All right, let's move into fevers, which are also referred to as febrile and pyrexia. Febrile is really just describing the state of having a fever, and pyrexia is more of a condition of also having a fever, having elevated body temperature. And it's really just a temporary resetting of our hypothalamic thermostat to a higher level. We know that our hypothalamus is the one that is going to set our normal body temperature. So we have an increase in heat production and conservation when we're trying to produce a fever. We are going to use exogenous pyrogens, and these are going to be fever-inducing substances from outside of our body. Usually it's produced by infectious organisms such as bacteria, viruses, and fungi. An example of this would be from gram-negative bacteria, which has an endotoxin known as LPS, if you remember talking about lipopolysaccharides in microbiology that are going to stimulate our immune system. And then we also have endogenous pyrogens, which are also known as pyrogenic cytokines. So once our immune system detects an infection, it starts to release these pyrogenic cytokines that are then going to signal to help induce a fever. So these cytokines are traveling through our bloodstream to the brain, specifically to the hypothalamus, where it's going to trigger that fever. Now you do see in this image over here that we have some interleukins at play and our tumor necrosis factor alpha here that are working, and these are working to induce that fever. So I'll just give some examples here. You don't have to memorize this, but interleukin 1 is going to be one of our major fever inducers. It stimulates the hypothalamus. IL-6 is going to amplify that fever response, and our TNF is going to initiate the inflammatory response and also promotes a fever. So sometimes we have a fever of unknown origin, high fever for longer than 3 weeks that is undiagnosed, and we're talking about higher than a temperature of 101 degrees Fahrenheit. And I believe this is unrelated to the to a release of pyrogens. So let's talk about what the benefits of having a fever is. Why does our body do this to us? And so our body is doing this to help us respond to an infection, of course, an attempt to kill a lot of the microorganisms within our body and decrease the serum levels of iron, zinc, and copper. This is going to be helpful because it will limit the growth of pathogens. A lot of bacteria, viruses, and fungi require these metals so that they can survive, replicate, and have their enzymatic functions. So if we restrict them, it'll help our immune defense. Also, we are going to promote lysosomal breakdown and autodestruction of cells, and a fever helps to accelerate the breakdown of infected or damaged cells by the lysosomes, and that helps to remove the pathogens and the damaged tissue. We also, through fever, increase our lymphocytic transformation and phagocyte motility, meaning that our fever is going to stimulate the immune cells, our lymphocytes and our phagocytes, to make them more active in identifying, attacking, and engulfing the pathogens. And lastly, it's going to augment antiviral interferon production and phagocytosis. So our fever will boost the production of interferons, which then enhances our immune system's ability to fight viral infections. Because if you remember, interferons will go and tell its uninfected neighboring cells to turn on their antiviral genes to protect themselves. And this will also support phagocytosis, where our immune cells are going to digest and destroy the pathogens. All right, next we have hyperthermia, and this is when we have an elevation of body temperature without an increase in the hypothalamic set point. So it's not mediated through pyrogens like we saw in the previous fever that we were talking about, but this can produce nerve damage and have convulsions take place. And we're talking about a fever that is around 105.8 degrees Fahrenheit or 41 degrees Celsius. And this can even lead to death if we get up to a fever of about 109.4 degrees Fahrenheit or 43 degrees Celsius. Also, having hyperthermia may be associated with a stroke or head trauma. And for a therapeutic hyperthermia, this would mean that we medically induce the hyperthermia to destroy pathologic microorganisms or tumor cells. This could be local, regional, or whole body. So we just got done talking about a therapeutic hyperthermia, but sometimes we can have accidental hyperthermia take place. And this could be through heat cramps, where we are going to have severe spasmodic cramps in the abdomen and extremities. This is then followed by prolonged sweating and is associated with sodium loss. And it's common in people who aren't accustomed to the heat, or they're doing a lot of strenuous work in warm climates. They may get a fever, a rapid pulse, and increased blood pressure that is accompanied with the cramps. And in order to treat this, we can give diluted salt solutions that are administered either orally or through parenteral routes. Now, with our heat exhaustion, this could be a profound vasodilation and profuse sweating that results in from a prolonged high core or environmental temperatures. This can, of course, lead to dehydration, depressed plasma volumes, hypotension, decreased cardiac output, or tachycardia. So you may see someone with heat exhaustion feel dizzy, have weakness, nausea, syncope, and confusion. And to treat it, you want to obviously stop the activity, lie down, and drink warm fluids. Next, we have heat stroke, and this is a potentially lethal result of a breakdown in an overstressed thermoregulatory center. Our brain can't tolerate the temperatures higher than either 40 degrees Celsius or 104.9 degrees Fahrenheit. So our cardiovascular and thermoregulatory centers can stop functioning at these high temperatures. With people that are having heat stroke, you'll expect that they have cerebral edema, degeneration of their central nervous system, swollen dendrites, renal tubular necrosis, hepatic failure, delirium, and can even result in a coma. Our last type of accidental hypothermia is malignant hyperthermia, and this is a life-threatening condition that's linked to an inherited muscular disorder, and it's typically triggered by anesthetics or neuromuscular blocking agents that's used during surgery. So if you're doing any type of surgical nursing, you really need to be familiar with this. This condition causes abnormal calcium release or a decreased calcium uptake in the muscle cells, and that leads to sustained muscle contractions. This then is going to increase oxygen consumption, which produces lactic acid, and it can result in serious complications such as cardiac dysrhythmias, tachycardia, and hypotension. So we want to recognize this early on so that we can prevent severe outcomes. The treatment is to remove the agent and cool that person down and administer drugs that are going to antagonize the ryanodine receptor. All right, now into hypothermia. This is when our body temperature is less than 35 degrees Celsius or 95 degrees Fahrenheit, and it's going to produce a depression of the nervous and respiratory systems. We're going to get vasoconstriction and changes in microcirculation and coagulation. We get ischemic tissue damage, especially if there are ice crystals that are forming inside our cells, and that of course will cause our cells to rupture and die. Now we have different types of hypothermia. Tissue hypothermia is going to slow the rate of cellular metabolism and is increasing our blood viscosity. It facilitates that blood coagulation we mentioned and stimulates vasoconstriction. When we have our therapeutic hypothermia, this is used to slow down metabolism and preserve ischemic tissue during surgery or limb reimplantation. Our ATP will be preserved with this as well, and we see this used a lot during brain surgery. With accidental hypothermia, it's going to result from an immersion in cold water, prolonged exposure to the cold, or altered thermoregulation, and passive or active rewarming can be used. All right, now when we have CNS trauma, it can lead to a central fever. This is a critical condition, and when our central nervous system is injured, it can trigger inflammation, increase intracranial pressure, and even intracranial bleeding. So unlike typical fevers, central fever is not going to induce sweating, which makes it a distinct clinical challenge. We're also going to see that it is resistant to our standard antipyretic treatments, which usually help a fever. And other forms of trauma can also affect temperature regulation, which is going to include accidental injuries, which is inversely related to the severity of the injury, hemorrhagic shock that triggers our peripheral vasoconstriction and hypoxia, and therefore is going to contribute to the hypothermia, and major surgeries in which the anesthesia can induce the hypothermia. And we can have thermal burns with skin loss. So our central fever and temperature changes that follow this type of trauma are going to require really careful medical management because it's complex and resistant to common treatments. All right, question here. Which part of the brain is responsible for temperature regulation? If you said hypothalamus, you are correct. Now let's talk about sleep. This is going to be an active multi-phase process that is going to restore functions and promote memory consolidation. So you can imagine how important sleep is to you memorizing this information. Our hypothalamus is going to be our major sleep center, and we have our hypocretins that are going to promote wakefulness and our REM sleep. And we have an area known as our pontine reticular formation that is primarily responsible for generating our REM sleep, and it projects from our thalamocortical network to produce non-REM sleep. So we are going to talk more about these two phases in the next slides. So here we are, REM sleep. It's going to account for about 20 to 25% of our total sleep time and occurs roughly every 90 minutes, beginning about 1 to 2 hours after entering your non-REM sleep. And it's often called paradoxical sleep because the EEG pattern during REM is very similar to that of being awake, despite our body being able to be in a deeply relaxed state. So during REM sleep, there's going to be increased parasympathetic activity with variable sympathetic responses also taking place, and that leads to the rapid eye movements that we saw in this previous slide over here. We also have muscle relaxation and the loss of thermoregulation. Our heart rate, blood pressure, and respiration can also fluctuate, and we can have memorable dreams at times. And notice in this figure that we have over here, as our night progresses, we're going to start to see that REM sleep periods will get longer and longer. And this cycle plays an important memory in our rest of our body. And as we said before, our memory consolidation. Now let's talk about non-REM sleep, or NREM sleep, which makes up about 75 to 80% of our total sleep time, and it's going to be a state of reduced activity. And you can see some of the comparisons here between the different types of sleep. And I want you to note that N1, N2, and N3 is referring to our non-REM sleep. So during this phase, our sympathetic tone is going to decrease while our parasympathetic activity will increase. And this allows our body to rest and recover. We'll see key physiological changes will include a drop in our metabolic rate, our body temperature, heart rate, respiration, blood pressure, and muscle tone. And these changes are going to be essential for physical restoration and helping our body to recharge. So this non-REM sleep is crucial for our health and our energy levels, and it'll support both of our physical and mental recovery. Now let's get into some sleep disorders. Excuse me. We're going to talk about these 6 classifications of sleep disorders. First, insomnia, which is going to be when we have a difficulty falling or staying asleep, which usually is going to lead to some type of daytime fatigue. We have sleep-related breathing disorders like sleep apnea that will be when we have interruptions in breathing during our sleep, and that can, of course, lead to issues with resting when we're sleeping. We have central disorders of hypersomnolescence, which is going to include narcolepsy, which is marked by having excessive daytime sleepiness and sudden sleep attacks. Then we have our circadian rhythm sleep-wake disorders, and this can happen when we have a misalignment between our body's internal clock and our external sleep patterns, which causes issues like shift work disorder and jet lag. And then we have our parasomnias. These would include abnormal behaviors when we're sleeping, such as sleepwalking or having night terrors. And lastly, we have sleep-related movement disorders, such as restless leg syndrome, that could cause discomfort, or maybe we're having some involuntary movements while we're sleeping. And of course, that's going to affect our quality of our sleep. All right, let's talk about dysnomnias. So one of the most important sleep disorders is insomnia, which, like we said, is going to be that inability to fall or stay asleep. And this can lead to symptoms such as fatigue, malaise, and difficulty with performing tasks during the day. And it can vary in severity from mild to moderate to severe. and maybe transient or chronic. It often is going to coexist with other common dysomnias, such as obstructive sleep apnea syndrome, which we're going to talk about next, where we're going to have our breathing repeatedly stop during our sleep. Hypersomnia, which is when we have excessive daytime sleepiness. We'll talk about narcolepsy and our circadian rhythm sleep disorders as well. All right, so like I said, we'll talk about this obstructive sleep apnea syndrome. This is most commonly diagnosed sleep disorder, even though it commonly is undiagnosed because of the nature of its symptoms. Risk factors would include obesity, male sex, older age, and being postmenopausal. And this condition occurs when there's a partial or total obstruction of the airways during sleep. So you can see in the illustration down here, we have our normal airway where everything is moving through and flowing well while we're asleep, whereas over here we see the soft tissues in the back of the throat are sliding back and blocking the airway. This can lead to things like excessive loud snoring, gasping, and multiple apneic episodes that last longer than 10 seconds throughout the night. And these interruptions in breathing are going to reduce the oxygen levels of our body and can lead to daytime fatigue, heart issues, and cognitive impairments. So we want to diagnose this early and treat it to manage the condition. So obviously this is going to disrupt our total sleep time, which leads to hypercapnia, where we're elevating our carbon dioxide levels and we get low oxygen saturation. And that can, of course, have serious consequences if we don't treat it. And over time, it could cause things like polycythemia, hypertension, stroke, heart failure, dysrhythmias, liver congestion, and edema. One of the hallmark symptoms is hypersomnia, or excessive daytime sleepiness, which can result in falling asleep during daily activities. And this can also impair mood, memory, and cognitive function. And we could diagnose this through polysomnography, which is a sleep study and is really the golden standard for diagnosing sleep apnea. Next up is narcolepsy. And this is a primary hypersomnia disorder that is going to disrupt our normal sleep-wake cycles. People with this are going to experience excessive daytime sleepiness and can suddenly fall asleep when it's an inappropriate time. And along with hypersomnia symptoms, we can include vivid hallucinations and sleep paralysis, and in rare cases, cataplexy, which is a sudden loss of muscle tone triggered by strong emotions. And the condition is typically sporadic and is going to be linked to immune-mediated destruction of hypocretin secreting cells in the hypothalamus, which is the region of the brain that really helps with regulating wakefulness. And now on to circadian rhythm sleep disorders. These are conditions that are going to disrupt our body's natural 24-hour sleep-wake cycle, leading to misalignment between our body's internal clock and the external environmental cues. So these disorders can have both extrinsic and intrinsic causes. The extrinsic factors will include rapid time zone changes such as jet lag, alternating sleep schedules, or shifts in total sleep duration. It's often seen in shift work. And then our intrinsic causes would include advanced sleep phase disorder, where people are going to feel the need to sleep and wake much earlier than usual, and also in delayed sleep phase disorder, where the sleep is delayed and the person is going to struggle to fall asleep until very late. So these disruptions can have long-term health consequences that would include things like risk of metabolic disorders, cardiovascular problems, and mental health issues. So we want to do a treatment that will involve adjusting sleep habits and light exposure so we can realign their circadian rhythms. Next, we have our parasomnias. which are a group of sleep disorders that are characterized by unusual behaviors during our non-REM stage 3 sleep, which is our deep stage of sleep. And these behaviors can include things like sleepwalking, night terrors, or even more complex actions like rearranging furniture and eating food or engaging in sleep sex. And in some cases, parasomnias can involve violent behavior, posing a risk to both the individual and others around them. And we also have the disorder of restless leg syndrome, which is going to cause an irresistible urge to move your legs. And of course, that disrupts your sleep. And this may be caused by a dysfunction in the brain's dopamine pathways that are responsible for regulating movement and sensation. And the treatment could be medications that increase dopamine levels in the brain, or iron supplements, or lifestyle changes. That will hopefully work. All right, next we're going to talk about special senses. So we know with vision, we're going to use our eyes. For hearing, ears. Olfaction or smell, we'll be using cranial nerves 1 and 5. And for taste or gustation, we will use cranial nerves 7 and 9. So first, let's discuss the eye. We have 3 different layers of the eye. We have the sclera out over here, where we have the thick white outermost layer. And then right over here, as we move to the anterior portion of the eye, it'll become transparent, and we call this the cornea. Now, our choroid is our middle layer, and that's going to be our deeply pigmented layer, and will consist of things such as our iris or actually, I'm pointing to the wrong place. Here's our iris, and then we have the hole in the center of the eye, which is the pupil. And then our innermost layer is going to be the retina, which is going to contain our rods and cones to serve as our photoreceptors. So we are going to get nerve impulses that pass along this optic nerve to the optic chiasm. So that would head on back and cross. And our light that's entering the eye is going to focus on our retina by the lens, which is a flexible and biconcave structure. It helps us to accommodate for things that are either further away or closer, so that our lens could be flexible and allow us to see different distances. Now, anterior to this, we will have our anterior chamber, and here we will have a fluid called the aqueous humor. And posterior to that lens, we are going to have the vitreous chamber that is filled with vitreous humor. And this fluid is going to be a little bit more gel-like, whereas the anterior chamber will have more, the aqueous humor will have more of a watery type of fluid. So let's talk about visual dysfunction. When we have alterations in ocular movements, that is going to be called a strabismus, where one eye is going to deviate, as you see over here. And if we have amblyopia, that is a reduced vision in the affected eye. Even with proper optical correction, this will take place, and it results from altered visual development. And then we have diplopia, where we can have double vision. Nystagmus is going to be when we have an involuntary rhythmic movement. We can categorize this as being pendular when we have a regular back and forth movement, or jerk when we have one phase of eye movement faster. And then paralysis of our individual extraocular muscles could cause limited abduction or abnormal closure of an eyelid, ptosis, which is a drooping, and then diplopia, which we said was a double vision. Now, when we have alterations in visual acuity, that means we are not able to see as sharp. With amblyopia, we will have a reduced or dimmed vision. Scotoma is going to be when we have a blind spot, and I tried to put some images on here for you to get an idea. So with cataracts, you are going to see a cloudiness in the lens. So even when looking at the person, and here they've illustrated that. So you see almost a fogginess here, like a clouding or an opacity with the lens. Treatment would be to have surgery to remove the cloudy lens and replace it with an artificial lens. Then we have our papilledema, which is edema of the optic nerve. And then we have dark adaptation. This is when we have a change in how well we can see when we're transitioning from a bright environment to a dark one. You may have a decreased ability to be able to adjust to low light, for instance. And then we have glaucoma, and this is going to be when we have increased intraocular pressure and atrophied optic disc and progressive loss of our peripheral vision. So we get something called tunnel vision. And you can see those changes taking place over here with the different types, closed angle or open angle. And I thought I had a picture of this, but imagine you would only be able to really see well in the very center of this image here. So when we have chronic open angle glaucoma, this is the most common form. The flow of our aqueous humor is slowed or obstructed. And in acute angle closure type of glaucoma, we have a rapid increase in our intraocular pressure due to the reduction of that outflow of the aqueous humor. And so we may have prolonged pupil dilation and total blindness within hours to a day. So clinical manifestations of this would be sudden and severe pain around our eye, nausea, vomiting, blurred vision, maybe even a redness to the eye, and colored halos around lights. So you want to get this treated with topical beta blockers or cholinergics surgery or a trabeculorectomy. The next one is our retinal detachment, and it is exactly what it sounds like, a separation of your retina from the underlying epithelium, which would allow fluid to collect. You can kind of see that over here within a space, and if it is untreated, then you can have loss of vision in that eye. With diabetic retinopathy, we can see that the cause is going to be in damaged blood vessels. So here's a healthy looking retina where you see all the blood vessels, and here we see that they are damaged in the tissue in the back of the eye, our retina, and we're starting to see some dark spots and strings in their vision. So you could see those spots and some lines in certain areas, and these spots are typically referred to as floaters and a little bit of a blurred vision as well. The last thing we'll talk about are age-related macular degeneration. This can either be dry or wet, and it's the most common cause of irreversible central vision loss in people who are 60 years or older. So when we have our dry macular degeneration, this is going to be the more common form of when we have accumulation of a yellow pigment in the retinal epithelium. And we see some atrophy and degeneration of the macular cells. With our wet macular degeneration, it's the severe form where we're going to have abnormal vessels in or near the macula densa. And if you look at this photo over here, you can kind of see where that vision is, or where the light is focusing in on. That's where your macula densa is. And so near that area, we're going to see the vessels will leak and form scar tissue. So we will have blurred or distorted and dark central vision. And sometimes we can have alterations in accommodation. Accommodation is, again, when we're going to shape that lens in order to focus on things that are far or near to us. We may have some oculomotor nerve changes. Remember, this is the nerve that supplies a lot of our extraocular muscles that we see pictured here. Manifestations would be diplopia, where we are going to almost feel like we're double visioned. And then we have blurred vision and headaches that can result. Presbyopias when we have a loss of accommodation with age, so we are probably going to need some reading glasses. All right, alterations with refraction is the most common visual problem. It's going to include irregularities in our corneal curvature, so in the front here, and focusing power of our lens and the length of the eye. So you can kind of see how the length is changing as we're going from A, B, and C here. So when we have myopia, that means we are nearsighted. This is actually what I have. So I can't see far too well. It starts to get blurry. And so we are seeing the parallel rays of the light are brought into focus in front of the retina. So it really should be right there. Then with hyperopia, we are going to see that in B over here, and the parallel rays of the light are coming in, but they're focusing behind the retina. And so we become farsighted here and have a hard time seeing things that are close to our eye. And in C here, we are seeing just simple myopic astigmatism. That's when we have a unequal curvature of our cornea. And what we're seeing in the red is that the vertical bundle of rays are focused on the retina, but these horizontal rays are focused in front of the retina here. So this can coexist with myopia, hyperopia, and presbyopia. We can have alterations in color vision. This can be age-related yellowing of our lens, or if we have color blindness, it's usually X-linked, and commonly we see that it is a red-green color blindness. We do see this more within males, and we can have acquired color vision with diseases as well. Now let's step into neurologic disorders. Vision can be disrupted at points along the visual pathway. As we said, we gather the photoreceptor information from the retina area and send it back through the optic nerves, which then are going to split and either cross at the optic chiasm or go back into the area in the thalamus that then sends back optic radiations to our visual cortex in the occipital lobe. So we can see issues here at the optic nerve or optic chiasm, and then we can have defects based on that, or even blindness where we're having the entire visual field affected or half of it, which is known as hemianopia. We can have several eye conditions that can cause discomfort and vision issues. So blepharitis is an inflammation of the eyelid that usually can cause a redness and irritation. And if any of you have experienced a hordeolum or sty, it's pretty painful and you get a red bump on your eyelid. It could be upper or lower, and it's usually due to an infected oil gland. A chalazion is similar, but typically it's less painful and results from a blocked gland as well. Then we have an entropion, and this occurs when the eyelid turns inward, and that could lead to irritation of the cornea. Conjunctivitis, I'm sure you've all at least known someone who has had this, but this is when there's inflammation of the conjunctiva. There's several different forms. There is an acute bacterial conjunctivitis, which is known as pink eye, and that causes redness and discharge and irritation. If we have viral conjunctivitis, that typically will follow a cold and is highly contagious. We have allergic conjunctivitis that is going to be from allergens and is usually accompanied by itching. And then we have trachoma, which is caused by chlamydia and is a serious form of conjunctivitis that could lead to blindness if it's untreated. And finally, we have keratinitis, and this is an inflammation of the cornea, and this can result from infections or injury and is going to need medical attention right away. So Let's now move into the ear. So we divide the ear into a external, middle, and inner ear. The external ear is used for hearing and bringing in those sound waves. We see the pinna and our external auditory canal here, and those sound waves travel and hit the tympanic membrane. That then is going to separate out this external ear from the middle ear in this region, which is also going to assist with hearing. And those vibrations from the tympanic membrane will vibrate through the malleus, incus, and the stapes. And this is also connected to, that should not say thorax, it should say throat, by the eustachian tube. This is sometimes also called the auditory tube. And that brings us to the inner ear. And actually, let me just mention real quick, this stapes is going to move in and out against the round window, which makes a connection to the inner ear. So we're going to look at these structures on the next slide. Here's our inner ear, which is not only going to help us with hearing, but also equilibrium. And so it is going to be composed of osseous, meaning bony, labyrinths, which are filled with a fluid known as perilymph. So you can see that purple here is kind of representing the perilymph. And we have the cochlea that really assists with hearing, our vestibule, and our semicircular canals here are going to assist with balance. Within the cochlea, we're going to have this important structure known as the organ of Corti, and this contains hair cells to allow us to hear. We also have some equilibrium receptors known as the crista ampullaris and macula. Now let's talk about some auditory dysfunctions. We can have conductive hearing loss, and this is when we have loss that is caused by typically cerumen impaction, meaning wax in the ear, and foreign body occlusion. So this will impair our sound conduction from that outer ear to the inner ear. Whereas when we have something that is sensory neural hearing loss, we are going to have an important impairment of that organ of Corti that we just talked about, or its central connections. And this condition can be presbycusis, which is a multifactorial sensory neural hearing loss, where we have a difficulty hearing high-pitched tones and conversational speech. It typically is going to be bilateral and is age-related. So you may have heard this be called as old hearing or elder hearing. But typically it's going to affect about 2/3 of Americans who are aged 70 or older. All right, what about mixed hearing loss? This is when we have a combination of conductive and sensory neural losses. When we have functional hearing loss, that's when someone appears not to hear and doesn't respond to voice. And then we have Meniere's disease, which is an impairment of the ability of our inner ear to regulate normal hemostatic systems. So it's more of an episodic disorder, and I know it says middle here, but it is of the inner ear that could cause a person to also get dizzy, and it could cause things like vertigo as well. Now let's talk about ear infections. We have otitis externa, which is going to be an infection of our outer ear, and it's commonly caused by bacterial infections, and the infection usually follows a prolonged moisture exposure. So this is also known as swimmer's ear. And moving to a different compartment in the ear, we have otitis media, and this is typically going to be acute. And it's when we have inflammation of the middle ear. So that's what all these images are of. At A, we see wax obstructing this external ear canal. Here we see what a normal tympanic membrane would look like. See that it's kind of pearly white here, and we can even see the malleus bone here over here. And then over here, we can see how it has become inflamed and red in an acute otitis media. We can see that it's bulging just a little bit. And over here, we can see otitis media with effusion, meaning that we're going to have some fluid in the middle ear that is building up. And then lastly, we see chronic suppurative otitis media, and we see a perforation where it has actually ripped, and we see pus within that area. So not a pretty look. All right, and let's move into the sense of olfaction. This is going to be sensed through the function of cranial nerve number 1 and part of cranial nerve number 5. It has a strong relationship between taste, and our olfactory stimulants can be our camphoriaceous, musky, floral, peppermint, ethereal, pungent, or putrid. And let's move quickly into taste, where we're going to use cranial nerves 7 and 9. Our nerves in the tongue and soft palate, uvula, which is that ball in the back of your throat, pharynx, and upper esophagus will help sense for taste. And we have some taste sensations or taste modalities, which are sour, sweet, salty, bitter, and umami, which means savory, or it's almost like that meaty taste is how I've heard it described. So when we have olfactory dysfunction, we can use some of these terms. Hyposmia is when we have an impaired sense of smell. Anosmia is a complete loss of the sense of smell. And olfactory hallucinations is when we think we are smelling something, but we're really not. And then parosmia is an abnormal sense of smell. Now for taste dysfunction, we have similar terms. We have hypogeusia, which is a decreased sense of taste, ageusia, which is an absence of sense of taste, and dysgeusia, which is a perversion of taste, meaning that you have an altered or distorted perception of taste. Now for our somatosensory function. We have our sense of touch, and we have many different types of receptors to assist us with this in the skin. So we have our Meissner's corpuscles. You can see them pictured over here. They will sense light touch. Then we have our Pacinian corpuscles, which will sense deep pressure. And then our Merkel discs over here, which also help with some light touch, and Ruffini endings, which are pictured over here. And they also will assist us with tactile discrimination, which tends to decrease with age. We've talked about proprioception a few times in anatomy and physiology, and it is, again, knowing where you are in space. And it really is going to depend on our inner ear and receptors in our joints, muscles, and ligaments to know where we are. As we age, we have a progressive loss of this, so we tend to lose our balance a little bit easier, and we are at increased risk for falls and injury. So it's really good to train for balance throughout our life so that we are not at risk. Dysfunctions can include vestibular nystagmus, which is an involuntary eye movement that is often linked to vestibular dysfunction. Vertigo, which is our sensation of spinning, and this is commonly caused by issues in the inner ear or brain. And Meiner disease that we talked about, which is a disorder of the inner ear that leads to episodes of vertigo, tinnitus, which is a ringing of the ear, and hearing loss. And peripheral neuropathies, which can affect the nerves outside the brain and spinal cord. It can impair proprioception that leads to balance issues and problems with coordination. So we want to make sure to manage these conditions and stay active to help proprioception. So once again, we can reduce our risk of falls.